Hello and welcome to the Alabama Public Health Training Network. The Community Health Assessment is a critical component of the national accreditation process that the Alabama Department of Public Health is currently pursuing. Today we will explain both the essentials of the accreditation process and also the importance of the Community Health Assessment to that process. I thank you for joining us today on our program, Community Health Assessment 101, a primer for Alabama Department of Public Health employees. Our objectives today are to explain the public health accreditation process and also to talk about the importance of it to the Alabama Department of Public Health. We also will discuss the top 13 health issues in Alabama and compare those to national data. If you have a question about anything being discussed today, please call or email us during the live broadcast. The phone number and the email address are both on your screen now, and they will also appear later in the program. Also, the handouts and the sign-in sheet and the evaluation are all available online, and you will need to register in order to be able to access these materials. Continuing education credits have been approved for nurses and social workers for today's program. The Alabama Department of Public Health is an approved provider of continuing nursing education for Alabama State Nurses Association. The association is an accredited approver of continuing nursing education by the American Nurses Credentialing Centers Commission on Accreditation. In order to receive credit for the training, you must watch the entire program and then complete and return the sign-in sheet and evaluation. Instructions on how to do this can be found at the bottom of the sign-in sheet. While content may continue to be relevant, CE credit will only be awarded for 2 years from today's date, which is July 17, 2014. Please note that the content of this program is based on the policies and procedures of the Alabama Department of Public Health and Alabama and federal statutes, rules, regulations, and guidelines. Viewers not employed by ADPH should always check to clarify whether the content is accurate according to the statutes, regulations, and policies of your respective jurisdiction or agency. I am Carol Heyer, and I am your Accreditation Coordinator and Performance Improvement Manager for the Office of Performance Management. And along with me today is Dale Quinney, who's the Data Information Specialist for the Office of Primary Care and Rural Health. So let's get started with our program. The first thing that I wanted to talk to you about is just a general idea of what accreditation is. Accreditation is just a process to measure an institution or an agency or a program against a set of quality standards that have been set forth by an accrediting agency. And the accreditation process has been established for public health departments now. By being accredited, you have recognition that you have achieved accreditation and that you are really providing public notification that you have demonstrated that you comply with those national standards of quality. Accreditation is not just a destination, it requires an ongoing commitment to improvement, development, and adherence to those standards. For state, local, tribal, and territorial public health departments, accreditation is determined through a process overseen by the Public Health Accreditation Board that we commonly refer to as FAB. FAB was founded in 2007 and it launched National Public Health Accreditation in September 2011. The purpose of accreditation is to improve and protect the health of the public by advancing the quality and performance of all health departments in the country. The overall vision is that our nation will have high-performing governmental public health systems that will make us a healthier nation. In conjunction with national partners and with support of the Centers for Disease Control and Prevention and the Robert Wood Johnson Foundation, FAB established the accreditation process and the standards for public health departments. And the Alabama Department of Public Health is currently pursuing accreditation as a state health department. To become accredited, our department is going to have to demonstrate and produce documentation to demonstrate that we meet those national standards that are established by FAB. The current version of the standards that will apply to us are Standards and Measures version 1.5. If you're interested in seeing a copy of those standards and measures, they are available on the FAB website, and you can see the web address on your screen now. You can also find out more information about the accreditation process in general by going to that site, and also see the list of accredited health departments. The FAB standards and measures are divided into 12 different domains. Domains are basically broad categories. And then each domain has standards and measures that are specific to that particular domain. And then each measure has some required documentation that must be produced by our department to demonstrate that we comply with that measure. And it's our goal to select the best documentation that we have as a department to present to FAB. Public health accreditation will document the capacity of our department to deliver the 3 core functions of public health and the 10 essential services of public health. And you'll see those represented on the graphic that's on your screen right now. The core functions are assessment, policy development, and assurance, and then the 10 essential services are listed there in the graphic. 10 of the FAB domains relate directly to the 10 essential services of public health, and the other 2 relate to our department's administration and governance. The accreditation process and documentation really focus attention on a lot of aspects of our department, but they specifically look at our leadership, our strategic planning, our engagement with our community. They look at our focus on our customers, our focus on our workforce. They also look at how we evaluate our department and our quality improvement efforts, as well as our governance. So you can see that accreditation really does declare that our health department has an appropriate mission and purpose, and that we're providing the range of public health services that we need to provide. Accreditation is voluntary. So why do we as a state health department want to be accredited? One reason is that it will lead to increased opportunities for resources. Accreditation will mean that we've produced evidence that validates for our public, our partners, our stakeholders, and our governance that we perform our responsibilities as a public health department with excellence. And demonstrating our capacity and capability can result in increased opportunities for collaboration, for resources, and for funding. Accreditation will also highlight our strengths and pinpoint our areas of improvement. It gives us an opportunity to look at ourselves. It also gives us the opportunity to get input from knowledgeable peers and public health professionals to evaluate, what are the things that we're really strong in, and then what are those areas that we need to improve. And then the improvements that we make can really lead to better health outcomes and make us a stronger and more attractive player in our changing healthcare system. Accreditation also improves communication and collaboration within the department. It can help improve our staff understanding about why we do what we do and how what we do fits into our department's mission and the delivery of the essential services of public health. It also can help break down some of the silos within our department to open up communication and understanding both across and up and down in the department, and reveal some opportunities for collaboration that may have been overlooked in the past. Another reason that we want to seek accreditation is to help develop the current and future workforce. One of the major focus areas of accreditation is workforce development, and that includes not only our current workforce but also our future workforce. In hearing from departments that have already become accredited, it also does a lot to have a positive impact on staff morale. Another reason is to raise our visibility. Accreditation helps clarify and validate the expectations of our department and really helps lay a foundation for defining and strengthening our role in the healthcare system. Also, our stakeholders will become more familiar with what we do as we strengthen and build our relationships with them. The last reason I'll mention today is that there's the potential for it to streamline the application process for grants. Already many grant applications are including language about your accreditation status. And if the department is accredited, there's a chance that the grant application may be streamlined somewhat because the department has already demonstrated that it meets the national standards set out by FAB. So how has our department organized itself to successfully apply for accreditation, and how can staff stay updated on the process? We have an accreditation leadership team that was reorganized in October 2013, and they've done a tremendous amount of work to get us ready to apply for accreditation. The team includes leads for each of the 12 domains, and these 12 domain leads have work groups. The primary responsibility of the work groups are to identify the documentation that we have that supports that we meet the standards and measures established by FAB, and also to get that documentation ready to submit to FAB with our application. The team also includes the leads for the document review panel. This is the panel that's taking a look at the documentation that the domain leads and work groups have pulled together to make sure that it clearly demonstrates how we meet that standard and measure. The team also includes the lead for the Accreditation Champions group that's focused on updating our staff on what's going on with the accreditation process and just letting you know more about it. Public health staff can keep updated on the process by taking a look at the employee documentation application. This is an area where the domain work groups are gathering documentation that they're considering for submission to the document review panel and ultimately to FAB. It also has a folder there where you can see all of the minutes from the accreditation leadership team and all the handouts that were provided to the team during their meetings. To access the employee documentation application, you can go to the document library and look for FAB employee documentation. There'll be a link there that you can click on that will add an icon to your Lotus Notes workspace for the employee documentation application, and then you can open and look and see what's there. We also have an accreditation website that's been set up that we'll be using to update our staff as well as our stakeholders about the process. So where are we in the process? There's actually 7 different steps in the accreditation process. We are currently in step 1, which is pre-application. We submitted a statement of intent to FAB on May 22nd, 2014. Our statement of intent is a document that we send to FAB that tells them that we've done our homework already to evaluate our department, and we've determined that we are indeed ready to apply for accreditation, and that it is our intent to send them an application within the next year. During the pre-application process, we complete our prerequisites, which are the Community Health Assessment, or the CHA, that we'll be talking a lot about today. We will also be completing our Community Health Improvement Plan, which is referred to as the CHIP. And this is both of those are collaborative processes with our stakeholders and partners. And the Community Health Assessment we'll be talking about today identifies what some of our health priorities are, and the Community Health Improvement Plan will be an opportunity for us to work with our stakeholders and partners to come up with a plan to address some of those priorities. The other prerequisite is the department's strategic plan, and that is unique to just our department. And work is going on all 3 of those. The second step in the process is the actual application. we submit our prerequisites with the application, and it's our goal to actually submit an application to FAB by April 30th, 2015, and we are on target for that at this time. Step 3 is when we actually submit our documentation to FAB. All the documentation that we're collecting and getting ready now will actually be submitted to FAB, and we hope to get that completed by September 30th, 2015. The next steps in the process are the site visit. This is where FAB will actually send some visitors to our state health department to verify the accuracy of the documentation that we've submitted to them, and also to get answers to some other questions related to our compliance with the standards and measures. The next thing that we receive is the accreditation decision, and if we are accredited, we will be accredited for a 5-year period of time. And during that time, we will send yearly reports to FAB to update them on anything that has changed about our health department, and also to update them on our opportunities for improvement that are being addressed by our department. The last step is reaccreditation. We will have to reapply for accreditation before our 5-year accreditation period ends, and basically that's just the full process that we are doing now. Our focus today is on the Community Health Assessment, or the CHA. The basic purpose of the CHA is for us to have an opportunity to learn a lot more about the health status of the population that we serve. It is developed through a participatory and very collaborative process with various sectors of our community. It will describe the health status of our population. It also identifies areas for health improvement. It determines factors that contribute to those health issues, and it also identifies some assets and resources that can be mobilized to address the population health improvement. Dale Quinney is here today, and he's going to give us a lot of great information about those 13 health priorities that were identified in the CHA process. But before I pass this off to Dale, I'd just like to take an opportunity to say thanks to everybody who participated in creating and developing our community health assessment for us, and also just for the many employees that are involved in the accreditation process. The standards and measures that are related to the CHA are basically outlined most clearly in Domain 1. And Dale Quinney, Stacy Adams, and Michelle Jones are our leads for Domain 1. And they, along with the Domain 1 work group and with support of the UAB School of Public Health, have completed our community health assessment. And I just want to personally thank you for all of the work that's gone into this. And Dale, I look forward to hearing about those results. Dale, tell us a little bit about yourself.
Carol, you left one name off with all the thanks, and that is yourself.
Oh.
I'd like to thank you very much for all of the assistance that you have been, as far as the assessment, as far as getting participation, not only inside of the Department of Public Health, but from the other components of our society. I don't know if I have ever had or ever experienced an easier activity. Okay. Healthcare involves every component of our society, and everyone has been more than happy to participate. Just to give you a brief example, I was asked to speak, invited to speak to the Economic Development Association of Alabama a few months back about health care, the status of health care in Alabama, in particular in the more rural areas, because we were beginning to lose some industries that we were recruiting because of a perceived lack of adequate health care. There's your industrial development and industry recruitment, just to give you an example of how this is not just a Department of Public Health activity. I was Director of Statistical Analysis with the Center for Health Statistics up until around 2000 when I retired. Now I'm working, what is retirement? Now I'm working part-time as an information specialist with the Office of Primary Care and Rural Health in the same department. And I'm also the executive director of the Alabama Rural Health Association. I am, as you can tell, one of those people who believes if you can't describe it with a number, then it's not worth knowing. So data is my niche. And let's get on talking about our community health assessment. We took an approach, and by we I'm talking about the work group, around 15 outstanding individuals that I'm having the honor of working with on this. We took the approach that we would like to gather as much information as possible from a very diverse part of our population, from all of our population, to have every county, every area, and every segment of our population represented and providing input. So what we did, we had 4 different surveys. We had a statewide survey of individuals. This was online and in paper copy, and over 6,000 people responded from every corner of the state and representing every component of our population. We monitored the responses as they were coming in to make certain we had every component of our population represented. We also had a statewide organizational survey, and over 500 different organizations within the state of Alabama responded to that survey. So we have very, very good participation in the individual and organizational surveys. There was also the Domain 1, the Community Health Assessment Work Group, and our expertise and years of knowledge of working with data, and along with that, we had all kinds of community interest groups and public meetings and surveys at the local level, specifically in the public health areas as designated by the Alabama Department of Public Health. These are groups of counties that act semi-independently in providing public health services for our citizenry in this state. Each of the public health areas compiled a listing through their activities, their local activities, of the top 10 healthcare issues or concerns, and provided that to our work group. We considered that information along with the knowledge that our work group had as our third component. And we also surveyed selected vital or very important components of our population, such as the educational industry, employers, transportation, hospitals, academia, so forth and so on, about 40 different components to make certain that all interests were covered. As with most things in life, there are acronyms. You will hear a few or see a few on our slides, so let me go over a few acronyms that you will see. Of course, ADPH is the Alabama Department of Public Health. BRFSS is the Behavioral Risk Factor Surveillance System. This is an annual statewide telephone survey directed by the Centers for Disease Control and Prevention to assure consistency from state to state. We tapped that resource for a number of the indicators that we're going to be using. I would encourage each of you to visit their website and take a look at the information that's there. It is a wealth of information, very good information and excellent service that CDC and in Alabama the Department of Public Health are providing. PHAB, FAB, is the Public Health Accreditation Board that we will have to seek our accreditation through. PHA, I've already addressed the public health areas. The top 13 issues as identified through our 4 activities. Now, why 13? We get each of the public health areas to identify their 10 leading. How did we come up with 13 out of 10? Each of the 4 approaches that we took, the 4 different surveys, gave us around 30 or 40 different concerns and issues ranked. The top 13 were identical in 3 of those approaches, 3 of the different surveys, and in the 4th, where it wasn't identical, the 2 that weren't, 11 were identical, and the 2 that weren't identical were the next 2 in line. So that's why we decided to go with 13. This is the first 7 of the 13 that you see on your screen right now. The remaining 6 of the 13, I'm going to discuss each of these individually, along with specific measures or indicators that we're going to use for each in developing a baseline, a starting point, and in monitoring progress on our work to intervene and improve each of these particular concerns or issues. These are ranked in the order of importance, in the order that they were given to us through the different surveys. So number 1, access to care, was ranked number 1 in importance. I don't think there's much debate over this. We have a number of barriers to access to health care in Alabama. I'm going to also, in addition to giving you what you see on the screen, throw in a few other items of interest that kind of play a little role in why each of these are so important and perhaps why they were selected for inclusion among the 13 leading healthcare issues or concerns in this state. We have a number of barriers to access to health care in Alabama. The ability to pay, the ability to be able to purchase health care insurance. Alabama has a high percentage of poverty, and we're experiencing a changing face of poverty in Alabama. In the past, when poverty was mentioned, the first thought would be the area that I grew up in and that my family still lives in, and that is the Black Belt area. Not so anymore. If you look at the most current data on per capita income, that is the income that is available to be spent per person, that's developed each year by the Bureau of Economic Analysis, there's a listing of the 250 poorest counties in the United States that comes out with those estimates each year. Alabama currently has 8 counties listed among the 250 poorest in the nation according to per capita income. That is the highest number that we've had since I have kept up with that information. These are not the counties that you would automatically think of. Those 8 counties are Bullock, that's a Black Belt county, Coosa, Bibb, Sumter, another Black Belt county, Wilcox, a Black Belt county, Winston, DeKalb, and Randolph. Poverty is no longer confined primarily to the Black Belt counties, and we need to train our thoughts to look at that in this new way, the changing face of poverty. Also, Marion County came in at number 251 on that listing. So you might as well say we had 9 counties among the 250 poorest in the nation, with only 3 of those 9 being your traditional Black Belt counties. The presence of providers, if we're looking at primary care, do we have primary care available in all of our areas around Alabama? That certainly, if it's not available, is a primary barrier to care. We have right now 5 counties, only 5 of our 67 counties, that are not either entirely or partially classified by the Health Resources and Services Administration as being a health professional shortage area. Only 5 counties, that means 62, are classified as shortage areas by the feds for the provision of primary care. Now, what I want you to remember there is whenever you see health professional shortage areas, we're talking about the provision of minimal care, not optimal care. So we only have 5 counties in Alabama that are providing above minimal care right now as defined by the federal government. Transportation or lack of transportation is another primary barrier to receiving health care in this state. We currently have 15 counties where between 10 and 17% of all households do not have a vehicle. It's going to be difficult to get anywhere under that kind of situation. Our population is not that healthy. Disability. We have 2 counties where nearly 10% of the entire population is on Medicare disability today. Approximately 1 in every 4 rural elderly residents of Alabama have what is described as a homebound disability. The first measurement that we're going to use of 2 in establishing a baseline for a starting point and then monitoring progress on access to care is the percent of uninsured population under age 65. Under 65 because, of course, everyone 65 and over are covered by Medicare. I'd like to mention what I'm providing here as far as the data. We're providing 5 bits of information on each of these indicators. Number 1, the number of Alabamians who are affected by whatever this measurement is. Here, 633,845 Alabamians under age 65 do not have health insurance. The second item of information is the conventional measure for that. For the uninsured population, it's percentage of the entire population under age 65. So you can see 15.8 or nearly 16% of all Alabamians under age 65 do not have insurance. The third bit of information is a little information to look at the historical trend. Is it increasing or decreasing? You can see that 5 years ago, in 2006, 15.7% of all Alabamians were uninsured. So really very little change since then, and I can see that is more than 5 years ago. Shame on me, and me being someone who works with numbers, I can understand if I'm fired. The next 2 items are to compare Alabama on that measure to other states. Regarding the percent of population under 65 uninsured, Alabama had the 24th highest percentage in 2012. And the last bit is the national measurement. 15.4% nationally were uninsured of the persons 65 and under. That's a little lower than the 15.7 for Alabama. So with each indicator, you'll be given those 5 different bits of information for your analysis. The second indicator regarding access to care is the percent of population that is experiencing a lack of primary care service and living in primary health care professional shortage areas. Currently, it's estimated that around 1,764,000 Alabamians are experiencing a lack of adequate primary care services and are living in health professional shortage areas. That is roughly 36%, more than 1 in every 3 Alabamians who are experiencing a shortage of primary care by living in a HIPSA. Now remember again, the HIPSA measures minimal care only. It does not measure optimal care. The number 2 health care concern that has been revealed through our community health assessment activities is mental health and substance abuse. You can see right here how inclusive this project is. Mental health care is not something that you traditionally see as being under the Department of Public Health, but it was identified by Alabama's population and the others participating in those 4 different activities as being the number 2 healthcare concern or issue in this state. Mental health care is also difficult to get a handle on. You have the Alabama Department of Mental Health, which provides many excellent services, but they're not alone. A lot of mental health care is provided by private industry, by private providers who aren't required to report that information. So it's difficult to really get a good handle on solid data regarding mental health care. But one measure that we are going to use is our intentional self-harm or suicide mortality rate. We had, during the past 3 years, over 2,000 Alabamians who committed suicide. We all know the devastation that accompanies such occurrences. Our mortality rate was nearly 14 per 100,000 standardized population. You can see that that's increasing from what it was 10 years ago. We had the 22nd highest suicide mortality rate in the nation, and we're higher than the national rate. 71% of all of our suicide victims were white males. Another indicator that we're going to use for mental health and substance abuse is the percent of adults who have ever been told that they have depression, that they suffer from depression. Nearly 22% of our adult population have been told that they have depression. That is the 6th highest percentage among all states. As far as the health professional shortage areas, they not only measure primary care, they measure mental health care as well. Only one county, Madison County, is not currently classified as being a shortage area by the federal government for the provision of mental health care. We're also working with the Alabama Department of Mental Health currently to see if we can't perhaps develop another measure for mental health care because of its importance. If so, we will have that included in the published assessment that we're going to be developing. Number 3 of the 13 was poor pregnancy outcomes. Being the executive director of the Alabama Rural Health Association, this is of special interest to me. Currently, 38, more than half of our 67 counties here in Alabama do not have hospitals providing obstetrical services. All 38 of those counties are rural. If you look at the 54 counties that the Rural Health Association regards as being rural, in 1980, 46 of those 54 had hospitals that delivered babies, that provided obstetrical services. Today, only 17 do. This is a very disturbing trend. If you look at the Black Belt area, the 12 counties that are generally considered as comprising the Black Belt area, it's even more serious. In 1980, 10 of the 12 Black Belt counties had hospitals that delivered babies. Today, 1. The hospital in Selma in Dallas County, Vaughn Regional, that is it. Ramifications for not having obstetrical service are great. That certainly can impact on the infant mortality rate because of the mileage that's going to have to be traveled to deliver. we can expect an increase in our cesarean birth rate. It's already 36%. 36% of all births last year in Alabama were delivered by C-section. Several because the moms had traveled such a distance that they were afraid if they left it up to nature that they would not be able to make it. So they elected that option. And I was told that by the administrator at one of our rural hospitals. Unfortunately, many times those who provide obstetrical service in the county are also the source of prenatal care in that county. Last year, 27% of all births involved women who had less than adequate prenatal care. The measures that we're going to use in monitoring and in establishing a baseline and monitoring progress regarding poor pregnancy outcomes, naturally the infant mortality rate. The infant mortality rate is internationally recognized as a thermometer for measuring the overall health status of a population. And I think you're going to see that that is quite true here in Alabama. We had over 1,500 infants lose their life during the first year of life in the 3-year period 2010 to 2012. Our mortality rate well exceeded the national rate, 8.6 versus 6.1. It increased slightly over 10 years ago. This tends to fluctuate each year, sometimes up, sometimes down. Alabama had the second highest infant mortality rate among all 50 states during that 10-year period. Now, I said that you were going to see that perhaps using the infant mortality rate as a thermometer for measuring the overall status, health status of our population was accurate. Alabama also has the second highest death rate. Even when age adjusted, crude or age adjusted, we have the second highest death rate compared to all 50 states. And this is spread throughout our population. Our youth under age 20 have the second highest death rate compared to that population in the other 50 states. Our what's called oldest old, age 85 and over, have the highest death rate among all 50 states for that particular population. The second indicator that has been selected to be used for establishing a baseline and monitoring progress on poor pregnancy outcomes is low-weight birth rate. That rate is a percentage. We had nearly 6,000 Alabama babies which weighed less than 5 pounds and 8 ounces, which is considered low weight, last year. That is roughly 1 in every 10 babies to residents of this state being of low weight. We have the third highest percentage of low weight births among all 50 states. The number 4 issue or concern, as identified through our activities, is nutrition and physical activity. We're going to be using 4 different indicators in establishing a baseline and monitoring progress on nutrition and physical activity. One, not surprisingly, is our obesity rate. 33%, 1 in 3 of Alabama's adults are not overweight but obese. And we all have heard about the health ramifications and challenges that come with being obese. 79% of all of Alabama's adult population are either overweight or obese. If you add the two together, that's 8 out of 10. We have the 5th highest percentage of obese adult population among all 50 states. In 2010, we were number 1. We have 10 counties where between 40 and 49% of our adult population are obese. The second indicator that we're going to use for nutrition and physical activity is vegetable consumption less than once daily. Don't really care for the way that's worded, but that means no vegetables daily. If it's less than one, then you have no vegetables daily. Roughly 1 in every 4 adult Alabamians do not have a vegetable on the average each day. We have the 20th highest percentage there, which doesn't bode well for the entire United States if we're 20th in people who have no vegetables per day. The third indicator for nutrition and physical activity is exactly the same but pertaining to fruits. No fruit daily. Fruit consumption less than once daily. Roughly 44% of all adult Alabamians did not consume fruit on an average of once daily. In other words, had none daily. That's the 8th highest percentage among all states for that particular measure. The fourth and final measurement that we're going to use for nutrition and physical activity is the adult population who participated in enough aerobic and muscle strengthening exercise to meet guidelines for adults. 15% of our adult population do not participate in enough aerobic and muscle strengthening exercise to meet guidelines. We have the 4th lowest percentage among all states on that particular indicator. Number 5 in the issues and concerns that were identified is circulatory diseases. One thing I would like to point out here, some new data that I learned about recently that is so revealing when it comes to circulatory diseases. The Centers for Medicare and Medicaid Services recently released what they call their chronic disease dashboard, which contains information by county and state and, of course, the nation pertaining to the Medicare population. This is those who are 65 and over on Medicare. They measure the prevalence rate of hypertension or high blood pressure. All 67 Alabama counties had a prevalence percentage among the Medicare population higher than the average for the United States. Yeah, you heard that right. All 67 counties were higher than the nation in hypertension. Hypertension is one contributor to our circulatory disease problem here in Alabama. The measures that we have selected for establishing a baseline and monitoring progress, there are 3. Heart disease mortality. The trend here is decreasing slightly, or decreasing, but still we have the 3rd highest heart disease mortality rate among all 50 states. We had nearly 36,000 Alabamians die during the last 3 years from heart disease mortality. Just to put that in perspective, that is more than the total population of Bibb and Perry counties added together, dying from heart disease over the past 3 years. The second indicator that we're going to use for circulatory diseases is the cerebrovascular or stroke mortality rate. Alabama is a very prominent member of the stroke belt, which starts in Virginia and goes to Texas, goes north to Kentucky, and even includes Indiana. We currently have the highest mortality rate from stroke among all 50 states. There's some good news there, though. You can see that rate is decreasing, but still we have the highest among all 50 states. The last indicator that we have for circulatory diseases is adults who have had their blood cholesterol checked and have been told that it was high. 42%, more than 4 in 10 adults in Alabama have had their blood cholesterol checked and were told that it was high. This is the second highest percentage among all 50 states. Number 6, and I'm sorry for getting behind on that. I thought I was current with it, but I was a couple of slides behind. I'm glad you're not here, so maybe I'm safe. Sexually transmitted diseases came in at number 6. You can see that nearly 39,000 Alabamians were diagnosed with sexually transmitted infections last year. That is roughly about 4 times the population of Greene County being infected with sexually transmitted diseases in 1 year. Our rate of STD infection is increasing. You can see from the data it has increased by more than 50% just since 2003. We have the 3rd highest rate of chlamydia among all 50 states, the 3rd highest rate of gonorrhea among all 50 states, and roughly the 15th highest gonorrhea infection rate among all 50 states, or syphilis infection rate. A second indicator that we're going to use for STDs is the new HIV rate. Alabama is below the nation as far as that rate is concerned, but we still have the 12th highest new infection rate among all 50 states. Cancer is number 7 as far as the ranking of health care concerns and issues. We're going to be using 5, I believe it is, different indicators for monitoring cancer. The cancer mortality rate is one. That rate is decreasing, but still we have the 7th highest death rate from cancer among all 50 states. The colorectal cancer incidence. We have the 12th highest rate of colorectal cancer incidence rate, that is, among all 50 states. There is tremendous variation by county when you look at that rate. Wilcox County had the highest rate, and Chilton had the lowest, with Wilcox County's rate being approximately 3 times that for Chilton County. We're going to be looking at female breast cancer incidence. Alabama has the 36th highest rate of female breast cancer. There hasn't been much change over the past 10 years or so, but there is great variation there by county as well, with Conecuh County having the highest rate and Covington right next door to Conecuh having the lowest. That needs to be looked at. That's difficult to explain. Conecuh County has a female breast cancer incidence rate approximately double that for its neighbor, Covington County. Another estimate that we're going to use, or another measurement that we're going to use for cancer, is the lung cancer incidence rate. We had nearly 39,000 Alabamians diagnosed with lung cancer during the 9 years of 2002 through 2011. That rate is not changing that much, but we do have the 10th highest incidence rate among all 50 states. There again, there is tremendous variation by county, with Winston County having the highest and Bullock County the lowest. Winston County's rate is more than double that for Bullock. The last measurement that we're going to use for cancer is prostate cancer incidence. Nearly 36,000 Alabamians diagnosed with prostate cancer during that same 9-year period. This is increasing. We have the 11th highest incidence rate among all 50 states, and there again, tremendous variation by county, with Hale County having the highest rate and Colbert the lowest. Hale County's prostate cancer incidence rate is more than 3 times that for Colbert County, and is by far the highest in the state of Alabama, well exceeding number 2, which was also another black belt county. Child abuse and neglect was the number 8 healthcare issue as identified through our efforts. We're going to have one indicator one measurement, and that is the child abuse and neglect reports completed by the Alabama Department of Human Resources. There were, during the fiscal year 2011 and 2012, the most current data that's available, nearly 21,000 reports involving over 28,000 children, cases of abuse and or neglect here in Alabama. There again, that number of children is more than 3 times the total population of Greene County, and that is involved in child abuse or neglect cases in only 1 year here in this state. We have great variation by county there, with the highest being Cherokee County and the lowest being Perry. Diabetes was number 9 among the healthcare issues and concerns. We're going to be using 2 indicators there. Diabetes-related mortality. Now what that is where diabetes was mentioned in any way on the certificate of death. We had over 11,000 Alabamians die from diabetes-related mortality during 2010 to 2012, the 18th highest rate among all 50 states. Now, if we had looked at diabetes as the underlying cause of death, where diabetes is credited with causing the death, not just simply being listed on the death certificate, we would have had the 9th highest rate among all 50 states. The second indicator that we're going to be using regarding diabetes is the percent of adults who have ever been told by a doctor that they have diabetes. That's 12.2% currently of the adult population that have been told by a doctor that they have diabetes. That's the 3rd highest percentage among all 50 states. We were ranked number 1 in the 2010 BRFSS survey. Another bit of information there, I mentioned earlier the chronic disease dashboard that the Centers for Medicare and Medicaid have. They also look at the prevalence of diabetes among the Medicare population. Only 5 counties in Alabama had a diabetes prevalence among the Medicare population that was below that for the nation. Diabetes is a very serious concern here in Alabama. Number 10 was geriatrics, or our aging population. We don't only have the aging of America, we have the aging of Alabama. The measures that are going to be used, and there are 4 of them, the projected percentage increase in our elderly population. Now, a little bit of information here, just for your interest. Elderly, when you hear elderly, that's talking about people 65 and over. If you ever hear the term oldest old, that is those who are 85 and over. Not what I would consider to be an overly complimentary term, but the definition of oldest old, and that is the term that is used in describing the population who's 85 and over. Centenarian is those who are 100 or over. They have lived for an entire century. And now, because life expectancy has been increasing for the most part, we have what's called supercentenarians, those who are at least 110 years of age. And apparently it's not a violation of HIPAA just to announce that these guys are still alive. You can go to a search engine on the internet and look up supercentenarian, and there's a website that keeps up with them on a daily basis to see who all is still with us and who is not. So you may want to do that. Go to Bing, Yahoo, Google, or something and look up supercentenarians. But the projected increase in Alabama's elderly population, those 65 and over, we are to experience an estimated 82% increase between 2010 and 2040. That is a little higher than the national percentage, but that still is going to pose quite a challenge for the healthcare industry. The healthcare needs just naturally increase with age. It has been estimated that by the year 2025, because of aging and the presence of chronic diseases that accompany the aging process, we can expect here in Alabama an additional 1,785,000 office visits to primary care physicians each year. Now, that's just office visits. That is not emergency room visits. The second indicator that we're going to use with geriatrics is the increase in the proportion of females age 65 and over who are up to date on a core of clinical preventive services. Currently, 1/3 of all females of our elderly females here in Alabama are up to date on the specified core of clinical preventive services. The big news there is 2/3 are not. We're going to be looking at the same thing with our elderly males. The increase in the proportion of males aged 65 years or older who are up to date on a specific core set of clinical preventive services. Currently, nearly 37% of all males aged 65 and over are up to date. The bad news, 6 out of 10, roughly 60%, are not up to date on that core set of preventive services. The fourth and final indicator that we're using for geriatrics is the adult abuse and neglect reports completed by the Department of Human Resources. I have inquired to see if we can get this just for the elderly. Adult is 18 and over. And we're going to try to get that just for the elderly population. But if you look, just during the last fiscal year, over 6,000 reports filed involving 6,400 adults, adult abuse. There again is great variation there by county, with Etowah having the highest and Winston County the lowest. Injury and prevention was ranked number 11 among the healthcare concerns identified through our activities. We're going to use 3 different indicators or measures there in establishing a baseline and then monitoring progress on injury and violence prevention. The homicide mortality rate. During the 3 years, 2010 to 2012, nearly 1,200 Alabamians lost their life at the hands of another intentionally. In other words, homicide. we have the third highest homicide mortality rate among all 50 states. If you look at the county level, there's even greater variation. Jefferson County has a rate 2.5 times that for the nation. Dallas County, 5 times that for the nation. Macon County, 6 times the homicide rate for the nation. This trend is decreasing, fortunately, but still, with us having the third highest rate, we have a problem, and our work is just starting rather than finishing. The homicide victims, 55% were African American males, and 52% were under 35 years of age. Now, you may be asking right now, what can the Department of Public Health do to prevent homicide? We had an epidemic of homicide, a small epidemic back in the 90s, and a presentation was made to the State Committee of Public Health. One of the physicians on the state committee asked that same question. He said, "We don't see the perpetrators or victims in our office. What can we do to try to intervene with homicide?" Dr. Williamson made a comment that has resonated since that time with me. He said, "We're going to have to try to intervene with homicide the same way we intervened with tobacco usage." You don't normally think of the two together. But he said society intervened and decided that it was a turnoff, that it was no longer cool to use tobacco. Think about it. You used to see on every television program and in every movie people lighting up. You don't anymore, because society determined that that was not cool anymore. He said the same thing is going to have to happen with homicide and other violent behavior to decrease it. Society is going to have to declare it as no longer being cool and portray it as not being cool. Accidental poisoning mortality is the second measure that we're going to use for injury and violence prevention. We have the 20th highest rate of accidental poisoning mortality among all 50 states, and that trend is increasing dramatically. Over the past 10 years, from 4.3 deaths per 100,000 population to 10.6, 2.5 times. Without change, without something happening, if you look at the accidental poisoning mortality that we have experienced here in Alabama over the past 10 years, unless something changes, it is going to overtake motor vehicle accidents as the leading cause of accidental death in this state by 2017. This has already happened in Walker County. In Walker County, there are already more accidental poisoning deaths than motor vehicle fatalities. And it's very close to happening in Tuscaloosa. Over the 3 years, 2010 through 2012, only 3 more motor vehicle fatalities than accidental poisoning deaths. If you look at this data, most of the victims are in their 30s, 40s, and 50s. It is much, much higher in North Alabama than South Alabama. And it seems to involve the use of illegal drugs and prescription drug abuse. We have a very serious problem with accidental poisoning. Hopefully, prescription drug legislation that was passed by our legislature recently and patterned after that in Florida will be effective. The last measure that we're going to use for injury and violence prevention is our motor vehicle accident mortality rate. This is decreasing significantly. It started decreasing in early 2000 when we passed seatbelt legislation. The very next year, our deaths from motor vehicle accidents in Alabama decreased by about 200. It had an immediate impact. But we still have the 5th highest motor vehicle accident mortality rate among all 50 states. This is the leading cause of death in Alabama among our Hispanic population because we have a young Hispanic population. This also varies tremendously from county to county by rurality, how rural the county is. The lowest current rate that we have is in Montgomery County, and the highest, more than 5 times higher, is right next door in Bullitt County, in rural Bullitt County. Number 12 is dental health care. Looking at health professional shortage areas, we have dental health professional shortage areas also, and currently only Shelby and a part of Madison County are not classified as a health professional shortage area for the provision of care to the low-income or Medicaid population. We have 3 counties in this state that currently do not have a dentist. Coosa, Lowndes, and Greene counties do not have a dentist in the entire county as of today. The second indicator that we're going to use for dental health care is the percentage of our adults who have visited the dentist or a dental clinic within the past year for any reason. Currently, 58%, or roughly 6 in every 10 adult Alabamians, have visited the dentist within the past year, which means 4 out of 10 have not. We have the 5th lowest percentage of those who have seen a dentist in the past year among all states. Number 13 is tobacco use. We have a tobacco belt here in Alabama. If you look at just about any indicator that is related to the use of tobacco, you'll see it higher in these areas. It's North Alabama, starting on the Georgia-Tennessee corner and going through the Birmingham area, down to Tallapoosa County, Bibb County, and on back up to Lauderdale County. It does not seem to include Madison right in the center of that area. And also in the south, much higher tobacco usage in Coffee and Dale counties. The first measure that we're going to use is the adult cigarette smoking rate. Roughly 1/4 of all adult Alabamians indicate that they are using tobacco, that they're cigarette smokers. That is the 9th highest percentage among all states. The other indicator is adolescent cigarette smoking within the past 30 days. This is data that's included in the Youth Risk Behavior Survey. Roughly 1/4, 22.9% of all high school students in Alabama indicated that they had smoked within the past 30 days. That is the 3rd highest percentage among all 50 states. That is the 13 issues and concerns that have been selected for inclusion in Alabama's Community Health Assessment for the accreditation process. That is by no means all of the health care concerns that we have in this state, but those have been identified by you, by our population, as the most important ones, the 13 most important. That includes what I have to discuss with you. Are there any questions or comments? This process is ongoing. It's not final. If you have any suggestions about other things, other measures to perhaps include, we're wide open to hearing about it. Are there any questions?
Dale, we have the opportunity for our listeners to send us questions by email. They can also phone those in. Do we have any at this time? We don't have any right now. I do want to thank you for sharing this information with us, and for what the work that the group has done to identify these issues. One of the first steps in solving a problem is identifying that you have a problem.
That's it.
And you've done a great job in sharing that information with us and really giving us a good perspective on what that problem really looks like in Alabama.
Well, the work group and those who have participated in the 4 activities have done the good job.
Yeah. The next step with one of the other prerequisites that we will be completing is the Community Health Improvement Plan. And this gives us an opportunity to take this information that has been pulled together through the community health assessment and actually work with partners and stakeholders to identify the areas that we really want to work together on to be able to move that needle a little bit to make some improvement. With the Community Health Improvement Plan, we'll be drawing together people who are interested in being a part of the solution of some of these problems and being able to come up with maybe some creative and ideas about ways that we can intervene and make a difference in these areas. The community health improvement process is not just a plan. It actually is something that gets monitored on a regular basis so that we can stay updated on our progress on addressing the issues that sort of filter to the top that we'll address through that process. Dale, how do we keep updated on this? This is, I know we have to create a document for accreditation, and that this is a snapshot in time, but how would we keep updated on our progress?
Carol, thanks for asking that. I meant to cover that earlier. First, let me mention also that my email address and telephone number are on the screen. I've given a lot of information and data that was not included in the handout. If anyone has interest in knowing where to obtain that data or seeing the additional data that is contained within the same sources that I referenced, please don't hesitate to contact me. Data is to be used. It's worthless if it just sits there and is not being used. We are going to, I just went over the contents of the community health assessment. That's going to be published in hard copy and also placed online in the Department of Public Health's website. But in addition, we're going to have a separate web page within the Alabama Department of Public Health's website where we will update those measures and those indicators just as soon as more current data becomes available. But we're also going to include a number of other measures and indicators that weren't selected among the top 13, but that certainly are of interest and concern here in Alabama. This is going to be an excellent resource for people who want to know about their local area. What is going on in my county? What are the healthcare issues in my county? You may be a member of an organization that would like to conduct an intervention. It's also going to be wonderful information for Alabama grant writers. And we need to bring as much grant money in as possible. The Department of Public Health wants to help you with that. So we will be providing that separate page, that separate resource that will include all of this data as current as it can be. It'll be updated as soon as new data is available, and it will include many more different measures or indicators. I believe we have a question.
Do we have a question?
We do. The question is, would you please list the poorest counties again?
Would you please list the poorest counties?
The poorest counties. Okay, let me flip over to that. Okay, that is, and these are in order from poorest to least poor: Bullock, Coosa, Bibb, Sumter, Wilcox, Winston, DeKalb. Those are among the 250 poorest in the United States. And I also pointed out, did I say Randolph? Did I mention Randolph, or did I stop with DeKalb?
DeKalb.
Okay. Randolph was also there. And number 251 was Marion. So the 8 counties that are in that 250 poorest counties listing, and then number 251, which we need to mention also, Marion County.
Do we have another question? All right. Dale, thank you again for sharing this information with us. I've heard this presentation several times now, and every time I hear it, I learn something new. Thank you for the energy that you put behind this and the wealth of knowledge and experience behind it, and just for giving us a good product to work from.
Well, thank you, Carol, and I'd like to thank those in our audience today for your interest in health care here in Alabama. And for those of you who work in the healthcare industry, I'd certainly like to thank you for your work and what it means to the people of this state. Our healthcare issues are great, and I'll be quite frank with you, it's kind of providing a little restraint for us attaining all that we can. It's holding us back a little bit. Alabama can be much greater than it is. It's already great, but it can be much greater if we have a good, healthy population.
Thank you for being with us today. I encourage you to take advantage of the resources that Dale has mentioned to you to find out more information about these health indicators and also about the accreditation process. On the screen now is information about how you can contact us for more information, and I encourage you to do that. I hope you have a good rest of the day, and thank you for being a part of this satellite today.